Good afternoon, everybody. Good afternoon. My name is Matthew Fuld from Siemens Healthineers. I am the product manager for photon-counting technology. And I'm very happy to have you here at our lunch symposium, Real-World Results, Cardiovascular Care with the World's First Photon-Counting CT. So we will have a great program. Hopefully you're enjoying your heart-healthy salads for SCCT and can really get a glimpse of what this technology can do. We've been talking about it at Siemens for almost 20 years in terms of R&D. I was one of the scientists at one of our early prototypes, and so to actually see it as a real device with clinical users all around the world is pretty amazing. So I will give a brief introduction about the technology, and then we have two real-world clinical users, Lynne Koweek from Duke University and Ricardo Budde from Erasmus Medical Center, who will join me in showing you the amazing pictures that you can see with photon counting. So I always talk about CT. I have to start somewhere, and you know, when we think about CT, we think about these three main things. It's about detailed resolution. So in this space, it's coronary plaque, it's the walls of the valves, it's being able to see edges of calcification with confidence. And so when you do that in conventional scanning, it's a trade-off between radiation dose and spatial resolution information. It's always a balance and a compromise. Speed is critically important, especially in cardiovascular imaging. If you can't stop the motion of whatever you're looking at, it doesn't matter what spatial resolution you have, it's irrelevant because it'll be blurry. And if you have a scanner that was developed in, say, maybe the last decade, you have probably moved beyond simple structure and moved into composition and function, what people call a lot of different things, I guess what the new SCCT lexicon calls multi-energy imaging, spectral dual energy. The challenge is that no scanner in the world could do high resolution at low dose, the speed to stop all motion, spectral information, all at the same time. And that's no longer true. The Neotome Alpha with photon counting technology built into a dual source CT can do all of these things simultaneously, and it really will have a great effect on cardiac CT. It's these four main technical principles, and if you were in the room munching on your lunch beforehand, you may have glimmered some of them from the video that I was looping, but contrast-rich images, better iodine signal because of how we weight the X-rays without diving in too deep into physics. The smaller pixels, without the need for light-reflecting septa, we can make much smaller elements on the detector, allowing you to go to much higher spatial resolutions. Spatial resolutions that we would have only achieved in the past at very high doses for things like the inner ear or the wrist, but we can now do them in the thorax, for the heart, for the lungs. Spectral information built into every scan because we measure the energy of every X-ray that hits. It's not an average signal, it's not a scintillator, it's not a multi-layer, it's every individual X-ray that hits, we know its energy and can use that for many advantages. And then because we can measure its energy, you can differentiate very easily between what is a real signal and what's noise. An X-ray needs a certain amount of energy to get through the body. So if it's at a certain level, it can't be there, it must be noise. And we can simply throw that completely away with this technology. A conventional energy integrating, as I mentioned, this is any scanner that you have if you don't have a Neotome Alpha, is this. It's a ceramic material. When you hit it with an X-ray, you create light. And in order to control the light, we have to put these walls in between them, light reflecting septa. If you don't do that, you have no spatial resolution. So you want to see the edges of the coronary, it's blurry. To get more resolution, you put in more light reflective septa. The challenge is that if an X-ray hits one of those, you get no signal. And so high resolution comes at an extreme dose penalty. All of the light is averaged together. We think of light as fast, but actually it's not fast enough to measure. We average the signal of about 30,000 X-rays together in a single projection, 1,000 projections as you go around. So no spectral information from the light directly. Photon counting is different It's a crystal semiconductor instead of a ceramic scintillator. When an X-ray hits the material, it creates electrical charge, electron hole pairs. We can measure directly. The amount of charge that is deposited is proportional to the X-ray energy, so we have the information of each X-ray impact. If you can measure fast enough, 8 nanoseconds, you can measure every individual X-ray, and that's what we've done. Faster electronics as well as smaller detector pixels. And so we have the ability to do those technological advancements that I mentioned. Smaller pixels giving us higher resolution by default, and ultra high resolution without a dose penalty. No electronic noise because we can simply threshold away what would be artificial signal. Spectral imaging in every scan. Not possible before in things like the coronaries. You could do it in the myocardium, get a sort of blurry picture of iodine intensity. Now you have the temporal resolution of dual source CT with spectral information, while you have better contrast information, because we handle the physics of low energy photons better, make them brighter. They're treated equally across the board. Built into dual source, so it's photon counting plus dual source. If you're familiar with the SOMATOM force, and I'm sure almost all of you are, it's the same temporal resolution, same volumetric speed, but with photon counting technology. That's 66 millisecond temporal resolution to give you high quality coronaries, any heart rate, anytime, any patient. Volumetric coverage for single heartbeat imaging, for triple rule outs, for the vascular portion of your TAVI exams. You can do any patient with dual source technology. Photon counting on the Natom Alpha takes that even further. It unveils impressive new details, high resolution by default, and ultra high spatial resolution. You can compare it to the force. The force has been the gold standard of CT in the industry for years, and you can compare these coronary images. The delineation, the detail on the Natom Alpha is just better at the same radiation dose. We get better quality. You can use that for heavy calcification. You can use it for stent imaging. You see the ringing inside the stent. It's a lack of spatial resolution. On photon counting, you can see inside the stent. Evaluate for plaque buildup, for restenosis. No more do you have to send someone to the cath lab for that diagnostic exam. You can do it on a CT scan with confidence. We can do ultra high resolution, 0.11 millimeter spatial resolution, 0.2 millimeter slice thickness in the heart. Eliminate calcium blooming, have high confidence. You can see the details here. Ricardo will show some great examples. It's part of our new software that was FDA cleared 3 days ago. So we're very excited to see it here in the United States. There have been great scientific publications proving the value, improving the identification of plaques prone to rupture, because you can do high resolution. The ability to see those small calcifications rather than the blurry soft plaque impression that you get there is dramatically different. We can see more and see it better. We can also explore more patients because we can use spectral information at the same time with high resolution. So we can eliminate calcium blooming as we've done here. So we can create a virtual non-calcium image. Keep the iodine signal, allow you to do a full CTA, but see the full lumen without the effects of calcium blooming. We can also use the better iodine signal to reduce contrast needs. It's a big challenge that we've all faced in the last months. By having better use of the signal, by having low monoenergetic in conjunction with that, we can really boost signal and use dramatically low levels of contrast. The delta here of 145 versus 55 mLs in this vascular scan. I argue the scan on the right is better. And get all of this without compromises, without sacrificing speed or spatial resolution, so that we can look at new endeavors, look at iodine distribution in the myocardium, look for scar, not sending somebody to an MR, sending them to a CT to try to drive these types of things forward. And so really, it's going to push the boundaries. You will see some really great images from the clinicians, and we're very excited to be here. So thank you for joining us, and it's my honor to introduce Dr. Lynne Koweek from Duke University, who will share her experiences.
Well, thank you, Matt, for that introduction. Welcome, everybody, to lunch and learn. First, I'd just like to thank Siemens for sponsoring the lunch and your continued support for SCCT over the years. Your partnership is much appreciated. Additionally, special thanks to Siemens, as well as all the manufacturers, for their continued partnership with all of us as clinicians for taking care of patients, because it is a team enterprise. So I'm going to start off and share a little bit about what we've been doing, just to give you a little bit of a background. I practice in a tertiary care hospital in the southeast of the United States, Duke University. Those of you who know Jonathan Leipzig, who I think many of you probably recognize the name, Jonathan did his fellowship at Duke. There's a trivia point for you today. Okay? We run a CT fleet of over 20 CT scanners. We provide community-based imaging, as well as we're a destination site for the Southeast, as well as North America and throughout. Oncologic care, cardiovascular care, pediatrics, you name it, we do it. So when we had the opportunity to onboard the Neotome Alpha, we had to do some serious thinking about how we were going to proceed. We overall are extremely happy with our quality of our cardiovascular studies, so it wasn't an issue of having to move from one thing to something else because we had a huge need for improvement. The CT scanner, the Neotome Alpha, came to us about a year ago on site, and we've been using it clinically for cardiovascular work for about 4 to 5 months now. Similar to all of you, we have had significant challenges over the past 2 years with staffing, access, you name it, contrast availability, and that has had to be taken into account. So when we started, we decided that we were going to take a little bit of a stepwise approach, and so since we liked our images, we decided we were going to go and compare our protocols and build based on the closest scanner we have. And we're fortunate at our institution that we already have 3 SOMATOM 4 CT scanners. And so the addition of the Neotome Alpha was to use what we learned and liked from the Force to build and get better. Because like all of you, we have challenging cases, but we also have the opportunity to improve. So where are our biggest challenges that we were looking that the photon counting technology could help us? Well, that was really with small vessels, heavily calcified small vessels, very large patients, where we were struggling with image quality, were probably our 2 best areas for where we saw the improvements, hopefully. Spatial resolution, and then the ability to have dual source or multi-energy imaging was the second thing that we were looking forward to, instead of having to pick a protocol to be acquired with a single energy versus a dual energy or multi-energy protocol was going to be helpful. So in comparison to the SOMATOM Force, the things that we really liked that we didn't want to give up at all was the ability to have dual source system mode acquisition. So we use the dual source mode for our cardiovascular imaging routinely. We didn't want to give up the fast temporal resolution that the Force gave us for our coronaries and cardiovascular gated studies. And we needed to maintain the ability to image large BMI patients. So we needed a good table weight and maintaining an adequate tube output. So if you see on this comparison slide, looking at the current dual source systems on the Siemens platform, the Drive, the Force, and the Alpha, there were things that we liked that we utilized. So we have, give me a pointer here. Middle. Yep, okay. So we liked the temporal resolution. We weren't going to take a penalty at all for our cardiacs. We liked the fact that our table load was going to be the similar, so we had no limitations for our larger patients. In fact, we had a bit of a wider board that we maybe were going to be able to play with. Our tube output was going to be similar. And right away, one choice we were going to have to make is how we were going to adjust from a 0.6 slice thickness separation collimation to that of the Alpha and the 144 by 0.4 or 120 by 0.2. We decided to go with a little bit of a conservative approach and what stayed with the thicker collimation instead of going to the thinner one, and I think Ricardo will talk to you a little bit about some of the choices they made. So we focused on 4 things that we wanted to work on. We wanted to focus on how we were going to utilize the improvements in spatial resolution for image quality and disease depiction. But with that, we had to think about making sure that we were going to have the appropriate contrast to noise or signal to noise and image quality characteristics, the texture of the images, as we worked through the reconstruction kernels that were going to be different on the scanner, knowing we were going to have to put in some time. Contrast opacification was very important to us for cardiovascular imaging. We have very robust protocols. We often, because of our patient size, have to put in very large IVs. So the opportunity to decrease contrast is something we're looking at, but right now we were focusing on maintaining homogeneous contrast throughout. We knew we were going to have to make some changes in that with this system now, the acquisition energy and the reconstruction energy were going to be decoupled, i.e. while you normally would pick your 120 or 100 kVp up front, knowing that's what your images were going to be reconstructed, that doesn't exist anymore on the photon counting. You pick your kVp for image acquisition, but you're going to reconstruct in a monoenergetic KEV. So there were some changes we had to think about there. And finally, we did not elect to use in our initial onboarding strong protocol changes to reduce radiation. Rather, we wanted to keep our radiation constant while we worked on the image quality aspects. And lowering the radiation dose would come second in our next iteration. And finally, we wanted to be very conscientious of workflow with a couple factors that we had to think about. One, it was going to be a whole new platform for our technologists, and they were going to need time to have adjust to a new monitor, an image acquisition, and the time to reconstruct the images. We had to be thoughtful for our workflow because our staff was tired. We had short staffing. We still are short-staffed, so we had to be thoughtful for how to onboard a whole new technology with nursing technologists and physician staff shortages. And finally, we had to be thoughtful in terms of workflow. How many data sets are we going to send to the IT system to pass on to PACS, given that we now could get more images? And additionally, with more reconstruction options, how many data sets, again, were we going to be passing through, and how many did we want to look at? So those were all the factors that really played into our first onboarding. And so I'm going to show with you some of our images that I've selected to put together just to show the breadth of cardiovascular work we've done and what we're seeing. So in regards to contrast opacification, these are 2 images from 2 different studies, just to illustrate both on a shorter axis, acquisition isolated to the chest, or on a long axis with the whole aorta, iliac vasculature. We were consistently seeing and have been seeing homogeneous contrast opacification from cranial to caudal positions. Depending on the KEV we were choosing, the contrast would be very high or could be lower, and we would choose those based on a little bit of the pathology. So in the second case, you could see we got a really nice separation of the contrast opacification from the calcified plaques, but no issues in terms of homogeneous or adequate contrast opacification. Here's a nice example with pathology, a chronic thromboembolism with chronic CTEPH. We are a referral site for these patients. These patients often are misdiagnosed at other sites, and we need to have confident diagnosis for surgical and medical decision making. So I think what you could see here is, first of all, you could see the chronic webs in the pulmonary arteries, a sequela of prior PE. But additionally, you can see, hopefully, there's extremely homogeneous contrast opacification throughout the entire pulmonary arterial system. And then additionally, what we were very pleased about is the edge enhancement we were able to get of the vessels. The texture of the images was well maintained and very high to our liking. We weren't having blurring of images or edge definition issues that often many sites were having to deal with when they went from filter back to iterative recon or changing from kernels. So we didn't have that problem at all. Now we work as a team, physicists, we have a dedicated team of medical physicists, clinicians, nurses, and technologists who are constantly assessing our image quality when we onboard new studies. Here was a case of this patient was a rather larger patient who came in through our ER actually it was an inpatient, for evaluation for pulmonary embolism and underwent PECT on an energy integrating multi-detector scanner. You could see on the image on the far bottom left, we were able to address an adequate amount of contrast opacification for the study to be diagnostic. Over 250 Hounsfield units is our threshold for how we like it. But when we were looking at the images, we had a couple areas that were a diagnostic challenge. Everywhere else, the pulmonary artery seemed fine. But in a couple areas in the left upper lobe here, and then down in here, there were some subtle findings that it was unclear if this was artifact or were these actually areas of clot. And this would really make a difference in the management of the patient, the clinical team felt. We didn't really have an option to consider switching to a VQ scan given the presence of the pulmonary emboli. The patient really didn't have the physiology and ability to do breath holding for an MR, so we would either have to go to a lower extremity Doppler and try to look for a clot in the lower legs to exclude it, or what we did instead was we moved them to the photon-counting scanner and did a repeat study. This study used the same acquisition protocols in regards to contrast. We didn't change anything, but what we were able to see is get a much better diagnostic data set. You could see right away the Hounsfield measurements were significantly higher, and this was going with the monoenergetic lower KEV reconstruction. But you could see here's the energy integrating image, and here's the images from the photon counting scanner. No question whatsoever, the one in the left upper lobe going anteriorly was artifact, but you could see here's clearly an area of incomplete filling consistent with a pulmonary embolism. So confidence for read, time to read the study was markedly improved for the clinicians, and we were able to get an accurate diagnosis. In regards to spatial resolution, what we're seeing is we can see better definition and more accurate depiction of smaller vessels here of the pulmonary arteries and veins. This also we're seeing with the coronary arteries. So these are images from a coronary artery CTA. The CPRs have all been reattached to each other to give a single one view. But you could see here the distal vessels are very well delineated out. Very nice edge enhancement similar to the PE study. No issue with interpretation. And even in this case over here where we've got significant hardware in the anterior sternum, we're really not dealing with, while we've got a little bit of streak artifact, it's significantly minimized and is well able to be read through without diagnostic challenge. This is an example, while I don't think it really fits necessarily into the realm of what is usually talked about at SCCT, and that is imaging of the thoracic duct and the lymphatics. I thought it was a nice example to depict the difference in spatial resolution for very small structures. This is a patient who was scanned twice for 2 different times, one with, energy integrating detector system and one with a photon counting. And this patient has Lipiodol in their thoracic duct after they had their thoracic duct occluded due to chronic and recurrent chylous effusions. But I think what you could see here is that the spatial resolution and the depiction of the branch vessels of the thoracic duct is markedly improved with the spatial resolution advances from the photon counting scanner compared to the electrical integrating detector here. And finally, for post-processing, the images generated from the PCCT are really nice for post-processing and 3D reconstructions. For vascular, you could see great images from the aorta, the pulmonary arteries, the RVOT, the right atrial appendage. You could see this nice image of a beautiful trileaflet aortic valve, but additionally, here's some nice images from the mitral valve where you start to see out more and more of the intricate structure of the mitral valve. Spatial resolution also we thought could be helpful for us for plaque characterization and better determining plaque characteristics, something that obviously is very important to all of us here. So this is an image from an aortic CTA, but you could see here now with the improved spatial resolution, we're actually able to better delineate out different, the characteristics and composition of the different areas of the plaque. So some areas being in the range of about 150 Hounsfield measurements, some fatty at negative below 0, and some varying more in the soft tissue range. So able to really, I think it's going to be a powerful tool for us as we want to look at more composition. Again, you could do this with the coronary artery, so another image with CPR images from the coronary arteries from the photon counting scanner. You could see that the calcified plaque, and we do a lot of patients with high Gadsden scores and high amounts of calcium. We do coronary CTAs. We definitely are finding that there's no limitation to doing those on the photon counting scanner for the ones we've done. And as you can see here, we can read through the calcified plaque without issue here. But also we can nicely pick out now and do again some Hounsfield measurements where we can pick out areas where there's calcium, pick out the very low fatty areas and the areas more of soft tissue density. We use the ability for the spectral imaging to help us out, particularly with calcified plaque, to reconstruct the monochromatic images at a very low KEV, so 55 KEV, to really boost the contrast opacification. Something in the past we were a little challenged with in the past with doing low KEV images and having a lot of noise. We're not finding that to be a problem for us now, so very low energy images with high contrast opacification and no issues for noise. You could see, the edge definition is very well maintained. We don't have any blurring, and we really don't have a modeled artifact. We then also reconstruct often with a very high KEV to help get rid of some, additionally to help get rid of some of the additional blooming of calcium. So we like to use these images in conjunction. So this goes again to workflow and how many data sets one is going to have to or select to pick. The other advantage with the spectral imaging capabilities is to get iodine-only images, and this allows you, so I've created the monoenergetic KV and then the iodine-only for both an aortic iliac assessment and a coronary artery, which really subtracts everything out but the iodine within it, and you still will see the calcified plaque, but it's much less prominent. These I find particularly helpful when looking at stenoses. And I'll finish off with two clinical examples where surprisingly, I shouldn't say surprisingly, but to our great delight, the photon counting scanner really sort of saved the day for us. This was a patient, one of a relatively early PE study we did, and the images were great, and I knew the techs were having a hard day. So after we saw the images, walked over to the scanner and thanked the techs. They're like, "Oh, we're so glad you like them, because when we finished the scan, almost all the contrast was sitting on the floor. The tubing came undone during image acquisition, and more than half of the contrast ended up on the floor, but we went ahead and scanned. And the images were reconstructed with 55 KEV, so this was a PE study done with 50 mLs of IsoView 370 in a standard-sized patient for us, and we were just absolutely delighted that we didn't have to qualify the study or be limited with the image quality. Additionally, this was a challenging patient that we had to image, a patient with a BMI of 85. I'm not sure how many of you do that, but that would be about 4 of me in your CT scanner. It's a very large patient to have to scan. This patient was imaged initially on one of our electric integrating detector scanners, which we really couldn't say much of anything except that it was a completely non-diagnostic study and we could not exclude or evaluate for PE. The challenges for imaging this patient, you can imagine there's not many other imaging options, so we decided to push the photon counting scanner and try our best to get a diagnostic study to at least exclude central PE. We knew we probably didn't have a good chance of seeing subsegmental or segmental disease, but we put the patient on the photon counting scanner, reconstructed with a KEV of 67, and felt pretty confident that we could exclude a large central pulmonary embolus, which really helped the clinical team. So for us, the opportunities for photon counting have been the high spatial resolution, maintaining the fast temporal resolution, and having the spectral imaging that can allow us to optimize contrast opacification, as well as we hope help us going forward with plaque characterization and tissue composition. And the nice thing is you don't have to think about your protocol up front ahead of time. Every case, every time, you can get all of this. So thank you very much.
Thank Thank you very much, Lynne. Wonderful talk. It's my pleasure to introduce Dr. Ricardo Budde from Erasmus Medical Center, who will share his experience. And we will hopefully have a few minutes for questions. We will, of course, stick around if you have questions and time runs out.
Okay, thank you so much, Matt, for the introduction, and thanks to Siemens for asking me to present some of our initial experiences with the photon-counting CT and the ultra-high resolution acquisition mode in particular. These are my disclosures. So, as all of you know, of course, CTA is excellent for rule out of coronary artery disease, but there are still some things with coronary CTA that are on our wish list. Of course, we want to reduce calcium blooming to improve the positive predictive value of CCTA. We want to improve coronary in-stent imaging. We want to visualize smaller arteries. We want to do more detailed plaque imaging. And we want to have more detailed imaging of prosthetic heart valves and endografts. And I think photon-counting CT, especially with ultra-high resolution imaging, can help in all of these areas. And that will improve diagnostic accuracy of CCTA, making more patients eligible for it, and improve also vessel segmentation. So on the photon-counting CT, we have two acquisition modes available at the moment. So we have the normal, which is also already a high-resolution imaging mode using 0.4 slice thickness, and which can be used, of course, with prospective and retrospective EKG gating, as well as flash acquisition. And then we also have the ability to do ultra-high resolution imaging, where we don't have an 0.4 but an 0.2 slice thickness at 120 slices that we can use. And that is what we call the ultra-high resolution acquisition mode, all using dual source imaging with a high temporal resolution of 66 milliseconds due to the rotation time of 0.25 seconds. This is our photon-counting scanner. We had it installed a little over a year ago, and up to now we have performed over 3,000 scans on the scanner. And what we immediately noticed when we started doing coronary imaging with photon-counting CT is that we could go up to much higher kernels. So this is an image scanned and reconstructed at 0.4 millimeter thickness, and the upper image is with a BV40 kernel, and if we reconstruct with BV48, we immediately see that we get a better depiction of the plaque, sharper edges, less blooming artifact, easier to assess the plaque, and probably also better for quantification of plaques. So we started to do that on a regular basis. So this is another example, a patient that has a plaque in a small OM branch, we located over here, and when we reconstruct that in plane with the vessel axis, we can immediately see that we can have a good visualization of the plaque. There's outward remodeling, there's good visualization of the vessel lumen, and we also can see that this is not only non-calcified plaque, but there's a small microcalcification in the plaque as well. Highly detailed imaging that we have not been able to do before. Then looking at stent imaging, also this is an 0.4 millimeter acquisition. Patient received a stent in the LAD for a previous non-STEMI. CT was done for a follow-up of stent patency. And this is done at a DLP of 129. So this is a relatively low dose scan. And notice that it's the lumen of the stent can be clearly assessed, where we can confirm vessel patency, stent patency. But also notice that the original plaque in the coronary artery, which has now been pushed out into the lumen of the LAD by the stent, can be perfectly assessed with photon-counting CT. Notice the level of detail that we have both in the stent as well as of the plaque and the surrounding epicardial fat. And remember, this is still with 0.4, so we're not yet at the ultra-high resolution imaging with this scan yet. We can also do it in a high-pitch acquisition. This is a patient that was scanned prior to pulmonary vein ablation using a flash scan, a protocol not specifically tailored for coronary assessment. Heart rate was low, 55 beats per minute, and we see that we also can get good image quality of the coronary arteries, even at this low dose of a DLP of 62, which, depending on the conversion factor, is either just below a millisievert or just above a millisievert. So very low dose imaging with high pitch acquisitions. This is a recent publication from the group by Zurich, in Zurich, that looked at specific reconstructions using ultra-high resolution, and they found that if we compare BV40 filters at 0.6 millimeters with BV56 at 0.2, we get a 16% reduction in blooming artifact. And that's also what we found, comparing BV48 with BV56, 0.6 versus 0.2, notice the improvement in image quality. This is a scan that we did in a patient after heart transplantation. For European standards, this is a big patient, BMI of 33, and we scanned the patient on the force 2 years previously. Similar heart rate, and also notice that the DLP is in the same range. Notice that the alpha images on the alpha have a much lower noise, so it's improved by a factor of 2.5 compared to the images on the force. And even if we go to a BV49 filter on the force, and even when we go down to 0.2, we get an even better image quality on the alpha. So this is another patient, post-heart lung transplant, relatively low dose, DLP of 155, scanned prospectively with a prospective EKG triggering, and at a high heart rate, 85 beats per minute, so not ideal for coronary imaging. And when we reconstruct the images at 0.6 millimeters with a BV40 filter, these are the images we get, already high resolution. But then if we go up to 0.2 reconstruction with a BV72 filter, so a very high kernel, we get an excellent image quality. Look at the level of detail we get of the plaques in the LAD, showing that this is not only calcification, but there is soft plaque as well. I mean, this is a level of detail that we've never seen before. At least I have never seen before when doing coronary CTA. And I think these are actually amazing images. It's not only the coronaries, also the other structures in the heart, for instance, the chordae tendineae here of the mitral valve, beautifully visualized, and as well here the tricuspid valve. Notice that we can even see the leaflets of the tricuspid valve in this CT scan. But we also use it in patients that are prior to TAVI planning. We use a 3-step acquisition, a non-contrast enhanced scan for calcium scoring, a CTA of the, for annular sizing, and then a flash scan to assess the entire vascular anatomy in the patient. And this is not an ideal patient because the calcium score is sky high, it's almost 1300. The heart rate is all over the place, varying from 133 to 62, highly irregular, so not an ideal candidate for scanning. But these are the images we get. Look at the level of detail we get from the aortic valve leaflets. Notice the small calcification here, how well it's depicted, and the tissue of the valve that we can be seen across it. And that at the heart rate that you've just seen, very high, very irregular. But also the coronary arteries. This was scanned at 0.2, then reconstructed at 0.6 with a BV40 kernel. And this is the LAD, and it's difficult to assess whether the lumen is patent here. But if we go down to 0.2 at BV56, notice how the calcification blooming artifacts have been severely reduced, and now we can assess the lumen. And this might open the way for pre-TAVI scanning, where we can actually visualize and assess the coronary arteries in enough detail to prevent the invasive angio, which is standardly performed prior to these procedures in our hospital. As a bonus, when we do the flash acquisition to assess the access route, this patient had 2 prosthetic hips. Notice the artifacts originating from the hip prosthesis. Using the IMAR, so the metal artifact reduction, we can get rid of almost all of these artifacts and be able to assess the femoral vessels in good quality. And then there are, of course, patients that have already received the valve. This is a patient after a valve-in-valve TAVI, patient with a BMI of 27, 94 kilograms, 70-year-old, and we scanned the patient to assess valve function. This is the level of detail we get of the valves. Notice the thickening of the valve leaflet here. So this is HALT, hypoattenuated leaflet thickening. And when we zoom in, you can see how well this is depicted. We even see that the valve leaflet, the tip here is not thickened. also notice the level of detail of the aortic wall. I mean, often we don't even see the aortic wall on a CTA, but here we can really visualize it in high detail. We can also, this was done with the retrospective EKG-gated acquisition, so we can do cine imaging, so we can nicely visualize the leaflet movement. This is the leaflet with the halt, which is moving normally. There's no severe obstruction or anything, but this is imaged at really, really high detail. And then, of course, the coronary arteries, again, showing the high level of detail from the plaques, the calcification here, even showing that that's not only calcification, but there is some non-calcified plaque on top of it. And when we take out one of these TAVI valves, and when you scan them ex vivo, what I really like is the level of detail you can get, because in these valve stents, there is this marker, this C, and you can never see the C on CT, but when you scan one of these valves with the photon-counting CT with 0.2, we can even see the C here in the valve stent, and I think that is truly amazing. So in conclusion, I think dual source ultra-high resolution photon-counting CT is here today. Especially the increased spatial resolution is going to help us with visualizing coronary as well as cardiac anatomy. We can use higher kernels routinely to increase the spatial resolution and the sharpness of the imaging. We can reduce calcium blooming artifacts, making more patients eligible for coronary CTA, improving plaque assessment and visualization, as well as improving prosthetic heart valve imaging. And with that, I'd like to thank you for your attention.
Thank you very much, Ricardo. Wonderful as well. I just wanted to end with 2 or 3 slides before we open it up to questions, because it's an important consideration. This is a completely new level of detector technology. We can't treat it like it's a conventional energy integrating system. The thing that we talk about first with our customers who are joining us on this journey and installing this, you can't treat it like it's a force. You have to move past it, because you get drastic levels of quality different. You can't just copy your protocols from one system and move it over. It's a consideration of the better spatial resolution. You can just do more without the level of noise. Those images that both Lynne and Ricardo showed clearly demonstrate. And so it is a process. It's not an immediate plug and play, but it's the concepts of dual source that many of you already know. You use them, but let's push the boundaries to see the level of detail and plaque that we can get. And so in order to drive this further, obviously we have standard education practices in the United States. You get your applications, but we've even developed a new role here in North America specifically focused on helping you, because it's a partnership. We want to invest in you. So every customer that is getting one of these scanners, our expert comes, visits, works with your physicians in addition to all the applications. That's typically for technologists. You don't get as much time. It's the ability to push the boundaries, because we want to focus on best practices. We know now what all of our institutions are doing around the world. How can we do this to push the field further? Do multi-center trials, multi-center studies. If we're doing different things in different sites, it's complicated. So we want to push the boundaries and drive it forward. And I open it to you as the experts in the field. Now that you can see the level of detail, the speed, the spatial resolution, spectral information, what are the questions that we need to answer? What are the new horizons that we'll be able to use? And this is what we need to explore together over the next number of years. So, really great. Would certainly be happy to open the floor up for questions.
Well, I suppose the first answer could be is you could go down and do the slot machines, but maybe that's not the right answer. I guess the second one is you could buy a Mega Millions ticket. It's up to a couple millions, but again, I'm not a betting person. Your point is well taken. Sorry. Your point's well taken. It's not a cheap machine, I believe, though I don't really deal with the business aspects for our purchases. But I think you have to decide where the cost savings comes. If you're repeating scans on patients, you're not saving money, right? So if it can fill a need for you to better take care of patients, then I think that's where the cost savings come. So it's sometimes on a bigger scope. It's not the cost of the individual exam, it's the cost across the entire care of the patient. Does that answer?
CPT codes today for cardiac CT, as we all know that we're fighting here, they don't cover the cost of the equipment. It's the overall patient care journey that they're getting. And what we see with this technology isn't the improvement in that patient care journey, because you are getting answers more quickly. You may not send someone for a diagnostic cath, so you're using your labs to do procedures rather than diagnostic. So you're saving time, making workflow improvements. Maybe you don't need scintigraphy, maybe you don't need ultrasound. You can drive an improvement in the workflow. Any other questions? Stunned into silence with the level of image quality. So there are many folks from Siemens here. You look down towards the ground, find the white sneakers with the radioactive orange laces, and easily know that someone from Siemens. We're happy to talk to you. We still have many cases at the booth. If you want to come see them on a workstation, it's different to see them live than on PowerPoint. But really, we're very excited for this technology. It's here. We have almost 50 of them installed in the world already, and many more install every week. So it's an exciting time to be in cardiac CT. So thank you very much for joining us.